to 3 positive axillary lymph nodes treated with breast-conserving surgery and whole breast irradiation.
Thank you very much for Mr. Chairpersons and ladies and gentlemen. As you know, that the role of radiation therapy for regional node irradiation for post-mastectomy patients are well recognized, like this very nice systematic review. They followed as long as 20 years, and as many as 8,135 women in 22 randomized trials reviewed. And this very nice review, in this review, the 1,314 women with post-mastectomy and axillary dissection with 1 to 3 positive nodes included. And as you see, radiation therapy reduced local regional recurrence at 10 years from 20 to 4%, and reduced any first recurrence at 10 years from 45 to 34%, and breast cancer mortality at 10 years, 36% to 33%, and at 20 years, from 50 to 42%. So it's clear that regional irradiation for post-mastectomy patient with 1 to 3 nodes patient to be treated by the radiation therapy. According to the data, the NCCN guideline version 2015 clearly demonstrate that total mastectomy with actual 1, 2, 3 positive nodes strongly recommended to PMRT, which include chest wall and regional lymph nodes. But how about the breast-conserving therapy? How about the role of regional nodes irradiation for those patient populations? As you know, there are 2 big clinical trials. One is MA20, and the other is EORTC 22922, 10925. And both of 2 data are already published in New England Journal of Medicine this year. And these trials are all of them treated by breast-conserving therapy, and 76% of patients are treated with EORTC trial. And many patients are enrolled, and 85% of the patients are corresponding to the 1 to 3 node positive, and 43% in this trial. And the clinical design was to compare whole breast irradiation with regional node irradiation versus whole breast irradiation alone. And this is versus whole breast irradiation with chest wall irradiation. And the results demonstrate there's no significant improvement in overall survival, but as you see, this is p-value is 0.06, and this is 0.06, so marginal the significance. But obviously, distant metastasis-free survival and local recurrence disease-free survival are both they obviously significantly improved with the irradiation to nodal regional nodes. And the complications associated with radiation therapy with a little bit the increased. This is the opposite, and this is also opposite. So obviously that's the inclusion of the irradiation fields to the regional node, the increased the pneumonitis and lymphedema, but this was not so significant from the clinical viewpoint. So it should be the consensus. The regional nodal irradiation is effective even for the breast patient with breast conserving therapy and 1 to 3 the actual lymph node involvement. But I still have the some clinical questions for the Asian population. It really needs regional nodal radiation therapy, and how about the unintentional dose to actual lymph node by conventional or breast irradiation? To answer those questions, a retrospective study was carried out. And between 1993 and 2010, 121 breast cancer patients with 1 to 3 positive nodes were enrolled. And all patients received standard tangential field or breast irradiations. Some of them used in the accelerated irradiation. And systemic chemotherapy and hormonal therapy was administered depending on the status of the hormonal receptors. And actual level 1, 2, and the ROTA area were contoured on CT and evaluated the dose volumetric parameters. This is a summary of patient characteristics. The younger than the 60 years old, the 43%, and the number of positive new nodes, the just one is 68%, 2, 24, 3, and 7%. And the median number of dissected lymph nodes was 13, from 2 to 60. And the median percentage of positive lymph nodes was 10%. And you can see the overall survival and the disease-free survival. The 95.6% at 5 years and 92.9% at 10 years for overall survival, and 86.6% at 5 years and 70.8% at 10 years as disease-free survival. I see that the clinical outcomes are a little bit better than the data in the Western countries. And as regards regional recurrence, only six patients, that is 4.9%, had regional recurrence. One is actual level 2 and 3, and 5 patients in supraclavicular fossa. And the 5-year regional recurrence-free rates are 97.4%. It's very good. And the pattern of first recurrence, the distant metastasis in 20, ipsilateral breast recurrence 5, and only 2 isolated regional recurrence were observed in axillary and supraclavicular area. And we analyze the factors which determine the regional recurrence. And age, lymphovascular invasion, hormonal receptor status, number of positive lymph nodes did not affect the rate of regional recurrence. Only pathological T stage that affected the rate of regional recurrence like this. And we also examined impact of radiation dose to axilla on regional recurrence-free survival, and dose to axillary nodal area by whole breast irradiations. On CT images, we contoured level 1 areas, level 2 areas, and also ROTA areas. And the median dose and volume delivered more than 40 gray was shown here, and the relatively large amount of dose was delivered to the level 1 nodal areas and also ROTA areas, but very little for the level 2 areas. And this is the impact of radiation dose to the recurrence. And you can see the median dose for level 1. This is less than the 35 gray and more than 35 gray. And this is the median dose for ROTA area, the same. And this is upper, the column shows the number of positive lymph nodes less than 20%, and this is more than 20%. And those data clearly shows that dose to the median dose to level 1 and ROTA didn't affect the regional recurrence-free survival, whether that number of positive lymph nodes was more than 20 or not. So the conclusion is that in our cohort, intentional radiation therapy doses to axillary lymph nodes using standard whole breast irradiation were not related to the regional recurrence. And T stage was a prognostic factor associated with the regional recurrence. Few regional recurrence were observed in early breast cancer patients with 1 to 3 positive lymph nodes treated with breast conserving therapy, followed by whole breast irradiation. And this may be associated with some kind of the ethnic characteristics. Thank you so much.
Thank you very much, Professor Hiraoka. The next speaker would be from